good afternoon. Thank you for joining us, Daniel. Um, you're going to do a presentation, I understand, on active connections, understanding depression, and other mental health outcomes in older adults. And we are glad to have this conversation with you today. For those who are listening in, Daniel Horrigan is a licensed master's level social worker who's engaged in interpersonal clinical practice at the Hannan Center in Detroit. He's a graduate of Wayne State, and Daniel has dedicated his career to empowering and celebrating the lives of older adults. So in addition to Hannan, Daniel has had the privilege to work at the Alzheimer's Association of Greater Michigan chapter and PACE of Southeast Michigan. So I'm now going to turn things over to you, Daniel. Thank you.
Great. Thank you. Thanks so much for having me today. Just to sort of give everybody an overview of what we'll be talking about. We're going to look at some common signs or symptoms of various mental health occurrences in older adults. This presentation has been sort of Frankensteined over time, and it's put together of different parts. Some of it is meant for professionals in the community. Some of it is meant for just lay people, clients, older adults themselves. So in regard, some of it you might think about for yourself, some of it you might think about for either somebody that you are serving or somebody that you are caregiving for. Yeah, just sort of a heads up there. But we'll go ahead and get started. And I'll put you on the spot, Stephanie, if you want to tell me a little bit about yourself and your role. And tell me one way that you practice self-care. Oh, you're on mute.
Okay, you are putting me on the spot. I'm the executive director at the Greater Detroit Agency for the Blind and Visually Impaired. And so I am doing a lot of things over here at the agency. So when you ask about self-care, your timing is probably pretty good. My self-care used to be a writing group that I belong to, because I am a romance author in my copious spare time. And so during the pandemic, though, I've actually kind of turned our backyard into a sanctuary. And so my self-care has become my gardening, planting trees and flowers and making sure that everything's growing the way that it should be growing. And then also on the side of my health, trying to eat a little bit better. I find that that makes me feel better as well. And so I think sometimes just being conscious of the fact that I need to take care of myself is its own level of self-care these days.
Yeah. I love that you're a romance author. That's so fun. like Stacey Abrams.
Yes, like Stacey Abrams, except I write fantasy. So
okay. She does like thriller romance, right?
Right. Yeah. So mine's a little more escapism than hers.
Cool. I love that. Great. Well, thank you for sharing. And just a few, we won't go through all of these questions, but at your agency, in terms of specifically social isolation or depression, what are you noticing within the folks that you work with and the folks that you serve?
A lot of the feedback I receive is that, when that initial diagnosis that people have lost their vision, for some people, it's been a gradual process and they've kind of known that it was coming. For some people, it comes more suddenly. But what I find that's kind of universal across the board is there is an absolute sense of loss when people have lost their vision. Many times that's accompanied by a loss in the ability to work, which is a loss of economic independence. There's also the loss of physical independence because people can't drive anymore. And, Michigan does not have the best mass transit system. So there are just many levels of loss that go into that. And I hear people wrestling with that for different periods of time. Some people have wrestled with that for years, and never really have come out of kind of that tunnel. So they're still grappling with that. So we hear a lot about that, the grief, the things that people miss, people feeling like they are now treated differently, because they're blind, and saying, I'm still the same person. I just can't see anymore, or maybe not see as well as I used to. So a loss of recognition, feeling invisible, the grief that's accompanying, the economic loss, the independence loss, feeling like a burden on family and friends, because you can't, quote unquote, take care of yourself the way you took care of yourself before. So really just a lot of just kind of a roller coaster of emotions for some people. And that varies with the level of support that people may have or may not have around them. And so finding people who've also been through similar experiences is difficult for people in this arena. It's just a really wide variety of emotional needs.
Yeah. It sounds like a real intersection of like grief and loss mixed with isolation and loneliness, because I imagine that your social situation changes.
Yes.
Like you said, transportation is so huge, right? So getting around, just being able to go out and do things, probably spending a lot more time on your own, which has its own outcomes, which we'll talk about. But yeah, that's all really key stuff, really important experiences. I think that those are also true just of the aging process for many folks. So we'll go ahead and we'll take a look at what are just signs and symptoms of mental health, that there might be something going on with somebody in regard to their mental health. We're going to look at things to look out for. We're going to look at common mental health disorders. We're going to hone in on isolation, loneliness, and depression. And then we're going to also talk a little bit about some interventions.
Okay.
But we'll do a little bit of an overview of some common things first. This can get a little brainy. I might skip over some of it. But if you're interested, you can let me know. No, keep going. I want to hear more about that. So when I meet with a client, I have to do something that's called a mental status exam. It's really just something that notes that I take based on what I am observing, right? So one of the first things that I will look out for is appearance. I'm a person with sight, so I look at how they're kept, whether they're unkempt, whether they're disheveled, if their hygiene is poor, and I'd have to document. That alone is not going to be something where I'm going to say, oh, they might have a mental health disorder, right? There could be a lot of reasons why a person might have poor hygiene, but it's something I'm keeping in the back of my mind. I'm also going to observe their behavior, their motor activity, whether there's any repetitive actions, any tremors, whether their eyes are darting about. That again might be some information for me. Agitation, hyperactivity. And again, not necessarily just a mental health disorder, could be a number of other things, but I'm filing it away. I'm also going to really pay attention to a person's mood and what we call their affect. So mood is sort of stated. Oh, I'm feeling really, I feel good is the mood, right? I'm in a good mood. The affect is, what is the face telling me? What is the voice telling me? Is that congruent with the mood or the content that they're talking about? And while I am a person with sight, since the pandemic, a lot of my work has transferred over to the phone. I don't know that prior to the pandemic, we had so much access or insurance was accepting that we could provide services just over the phone, but we've met people where they are. The healthcare industry has met people where they are. So I do have to put together a lot of this. So I also think about vocal affect. So that might be one way folks in your community might hone in on some of these things. So vocal affect is, does a person sound really flat, right? Are they very monotone? That might be what I call blunt or constricted. If you can see their face, is their face constricted or restricted, right? Is the person labile? Is their sort of emotions and vocal patterns going up and down or all over the place? Is the person euphoric? Are they in an extremely good mood? Like where that good mood, there isn't necessarily, they didn't just win the lottery, but they're coming in with this really, really excessively good mood. Or are they dysphoric? Are they in really, really down, feeling very dark, feeling like they can't see past whatever the problem is in front of them? And is all of this going together, right? So if I have somebody who is telling me a really sad story and laughing all the way through, then that's a red flag. That's something that I'm going to have to examine a little bit more. So if I have somebody with poor hygiene who's hyperactive and is telling me some really challenging stuff and is laughing intermittently, now I've got some information that maybe this person has a mental health disorder. So there's just a lot that we can really observe, either by their content, their appearance, their vocal inflection, but also how are they thinking? So their cognition. Is the person sharing delusions? Are they sharing hallucinations? Delusions are generally a belief, right? Somebody's after me, the aliens are after me. A hallucination is seeing something that you and I don't see, something that to us is not there, right? Are they having a lot of fleeting thoughts? Are their thoughts sort of one right after the other? Are those thoughts also not matching up? If you ask a question and they're answering with something very different. So, tell me how work went last week. Oh, me and my buddy, we did this and we went and, we went out the other night and and you're noticing that that's pretty constant. Again, these are thought patterns that are red flags. So these are some of the challenges. These are some things just to keep in mind if you're working with somebody or talking with somebody that you're caregiving for, or just that's in your life, that maybe they might need a referral to a mental health professional. And this is true for everybody. This is not specific to older adults. So a typical presentation, you and I right now, broad affect. I'm smiling here and there. I'm calm, I'm relaxed. My mood is congruent with the circumstances. I'm on topic. My range of affect, if you say something funny to me, I'll laugh. If somebody tells me something really, really sad, I'll empathize. I'll show that on my face. My speech, my thoughts are clear. I hope they are. I hope you're all following this. My speech is clear. I'm understandable. If you ask me questions, I'm answering things accordingly. And I also have insight into my situation. I understand what's happening. So that's sort of what the goal is, right? If you're noticing any of these, any of the other circumstances that I mentioned, there are some common disorders that these can be attributable to. The first and foremost that we always want to identify and rule out before we jump to anything else is substance use disorder. Is this person sort of all over the place in their speech? Are they, is their hygiene poor, and are they shaking a bit because they've taken a drug, or they've been up for many days on some sort of drug? Are they inebriated? So is there some kind of alcohol use disorder or substance use disorder? That could be a key thing. Schizophrenia is a pretty prevalent diagnosis, particularly in the 70s and 80s. I think a lot of people were misdiagnosed as having schizophrenia when maybe they had a bipolar disorder or something like that. But schizophrenia, those hallucinations and delusions that I talked about, those are often associated or attributable to schizophrenia.
Can you talk maybe a little bit about the differences between schizophrenia and bipolar? Because I feel like people use those interchangeably, but I know that there are differences.
Yep. And I'll get into that for sure.
Okay.
So schizophrenia, when we think, and I'll just give you like broad overviews, but that will hopefully really distinguish it. Schizophrenia is, when we think of schizophrenia, we want to think hallucinations and delusions. Okay. We also want to think of maybe grandiose ideas, a grandiose sense of self. You know, people are on a mission to change the world. They've got some message from, you know, some religious message that they're here to share. They've heard, you know, voices telling them things that they need to do. That's an example. Not all schizophrenia is of that specific type, but I'm just giving you an example. Okay. Bipolar disorder. So when we think of bipolar disorder, we want to think of a person who's down, depressed, and or manic. So this is more, I guess you can sort of think about it as energy levels and activity, where again, schizophrenia is really going to be hallmarked by those hallucinations and delusions. Bipolar disorder is going to be more about episodes of feeling really down and depressed, and or episodes of feeling really euphoric or a lot of manic energy. And there's two types of bipolar disorder. So bipolar type 1, it must include a manic phase. So the mania has to be present. There may be a depressive phase, but what we're really looking at for bipolar type 1 is that manic phase, which often starts off as like a high. It's euphoric. It's, I'm getting things done. I've got all of these plans. I'm organizing and cleaning, and it can evolve into just sometimes destructive behavior as that crash, as you know, it sort of veers into a crash, and also kind of collides with being up, like not getting enough rest. Bipolar type 2 includes what we call a hypomanic phase, where it is that up phase, but it's not as severe as a manic phase. They don't necessarily reach mania. And in bipolar type 2, the emphasis is on the depressive phase. Okay. So we have a really, we'll see a much more significant occurrence of depression. So that's just to sort of give you an overview now, just to make it a little confusing. And these are a little less, this is a little less common, is schizoaffective disorder, which is sort of a combination of schizophrenia symptoms with mood disorder symptoms. So if you have somebody who is having those hallucinations and delusions, but also has really, really high energy and is in a manic phase, they may have schizoaffective disorder. Now, all of this being said, when I work with clients, they will tell you, oh no, my bipolar is like this. I don't always get this. I don't always have this phase. So again, these are generalisms, but we're gonna let individuals be individuals, and they'll tell us how their mental health manifests. So what's interesting and what I've come across a few times in working with older adults is is, does somebody have schizophrenia or does somebody have Alzheimer's disease? Especially when you start to think about hallucinations and delusions, it's common in Alzheimer's disease. It's probably starting at about middle stage for people to be seeing things that aren't there, to be having conversations with folks that aren't there. So, and I've actually seen people misdiagnosed as having Alzheimer's disease when in fact they're having a schizophrenic episode, right? They've come in, we don't have any of that history. We don't know. Sometimes people come in without a history and you're like, well, she's 70 something and it's our first go-to, right? If we see some of these symptoms that she's got Alzheimer's. The reality is that often these mental health disorders, they will calm as a person ages. So we'll see stronger episodes of schizophrenia. I mean, schizophrenia is usually clocked at about in someone's 20s or 30s. And a lot of times they'll reach sort of especially if they are being treated appropriately, they'll sort of reach a remission with it. But people untreated, might still be having episodes and be confused as having Alzheimer's disease. So just some ways to kind of distinguish the two. For delusions is a symptom of both Alzheimer's disease and schizophrenia. Within Alzheimer's disease, those delusions usually focus around theft. Somebody stole my wallet. Somebody stole my purse. Somebody stole my keys. That might be that person believes that because they've misplaced them and they don't remember where they've placed them and they're not aware of their diagnosis of Alzheimer's disease. Infidelity and persecution. In schizophrenia, persecution is a common delusion, but it's also about thought control. Someone outside is telling me things and telling me what to do. We don't hear that too much in Alzheimer's disease. Hallucinations. In Alzheimer's disease, visual hallucinations are more common. In schizophrenia, auditory. It will be more auditory. I've heard voices. Presentation, Alzheimer's disease will be more of a flat affect, poor speech, like they can't really get words out, or their speech is really muttered. In schizophrenia, it's more of like speech is fine, but just think disengagement. Family history, Alzheimer's disease, it does have a correlation with some family history. It's not, I don't think it's, there's a back and forth about whether it's genetic. Schizophrenia is also, we can actually sort of skip this row because I don't think it's very clear. The trajectory of Alzheimer's disease is that it's progressive. The decline is progressive with aging. With schizophrenia, we're not going to see a set pattern. It fluctuates. So just some ways to sort of distinguish those two. So now we'll focus in our conversation past these sort of big ones, right? And talk about mental health occurrence or disorder that is much more common and also kind of insidious in how it arrives and it appears and manifests in a person's life and their mind, and can sometimes just be accepted as normal. So we're going to talk about depression, but first let's talk about isolation. Let's give a little definition to isolation. So isolation is a state of being. It's a lack of social connection. It's a lack of companionship. And while it can lead to loneliness, it's not the same as loneliness. So isolation is a person who's primarily on their own, whereas loneliness is an emotional experience. and I don't know if I'm going to say this later in the thing, in the presentation, but I'll just say it now. Not everybody who is isolated is lonely. Some people enjoy their independence, enjoy their time alone, are very at home with themselves. So a person can be isolated and not be lonely. So what are some risk factors of isolation, of a person being on their own? So chronic illness, death of a loved one, hearing loss, physical impairments. I mean, this is basically all of the things that you said when I put you on the hot seat. Loss of mobility, living alone, and a pandemic, right? So that's our new one. All of these others, we've certainly existed, but the pandemic has really shined a light on social isolation and has gotten people talking about it and thinking about it, because the news is that older adults didn't need a pandemic to be socially isolated. All of these other circumstances are something that people who are aging have always experienced. Chronic illness, loss, hearing loss, vision loss, physical impairments, loss of mobility. These are very isolating experiences. So people who are experiencing those things, we want to keep them in mind. We want to check in on them or maybe create supports. Just some statistics here for you on isolation and loneliness in older adults. More than 1/3 of adults aged 45 and older feel lonely. 1/4 of adults aged 65 and older are considered to be socially isolated. It's 1/4 of people 65 and over that are considered to be socially isolated. 19%, I'm just going to go ahead and say 20, I'm not worried about it. Nearly 20% of older adults over 60 report feeling lonely fairly frequently. So that's a pretty significant number. When I hear 20%, that's a call to action. So let's look at how, and those statistics that I've just quoted you, those are all pre-pandemic. So let's take a little look at some data that was taken by the University of Michigan's poll on healthy aging. This was done, I want to say 6 months into I know it was done in 2020, in later 2020. I'll be interested to see more data. I think it's just been hard to clock some of this data around isolation and loneliness because the pandemic has been such an up and down thing where people are extremely isolated, and now we can be social. Now we're really isolated again. And so we keep going back and forth. Summer's here. It feels like it is this week anyway. Maybe we'll see a little bit more freedom, but I'm really curious when the fall comes. Are we going to see another heavy strain and another lockdown? I don't know. But 56% of older adults felt isolated compared to 27% reported in 2018. So in 2020, that number of older adults who felt isolated jumped about 30%, from 27% to 56%. 48% of older adults felt more isolated during June 2020 than prior to the pandemic. 46% of older adults reported infrequent social contact at a rate of 1 visit per week or less. So 46% of older adults reported infrequent social contact, and this is up from 28%. So no doubt that this pandemic has, really agitated this experience, which they call social isolation or loneliness prior to the pandemic, they were calling it a new epidemic and thinking of it as a really significant health crisis. So prolonged isolation has the same effect on one's health as smoking 15 cigarettes a day.
Wow.
I don't believe that means necessarily, and it's not in terms of like your lungs, but in terms of your physical health, your mental health, and your longevity.
Right.
The risk of death increases by 26% in those who are lonely and isolated. You do have an increased risk of cardiovascular deaths, and you have a risk of death by suicide or accident that is doubled.
That's significant.
Yeah, it is. It's very significant. So impact, hang on a second here. Impact on loneliness, impacts of loneliness on cognition. Older adults experiencing loneliness are at an increased risk for cognitive decline. And there's lots of reasons for this. I mean, I think some of it is really obvious and basic. The more you are alone, the less you are utilizing your cognition, right? Engaging in conversation, engaging in question asking, engaging in question answering. That's utilizing all of your cognitive processes. People who are isolated, lonely, and depressed are less likely to also just engage in activities that will keep your brain sharp. Older adults experiencing loneliness are more than twice as likely to experience symptoms associated with Alzheimer's disease. Older adults experiencing isolation may be at risk for experiencing depression, or they may be experiencing depression due to isolation. So what came first? So here I have a picture of a chicken and an egg with some arrows, because what came first, the chicken or the egg? What came first? My mental health has made me lonely, or feeling lonely has damaged my mental health? It's a cycle. It can be a vicious cycle. Some folks might be able to identify where it began, others won't. I don't think it matters. The idea is, when we talk about interventions, which I'll talk about in a little bit, the idea is to disrupt that cycle, right? Doesn't matter which end we're coming from. We're going to find a way to disrupt that. So symptoms of depression. Let's talk about this, because this is pretty common. Your two hallmark symptoms of depression are taking little to no interest in or pleasure in doing things that you might otherwise enjoy, and feeling down, sad, depressed, or hopeless. So those are the two big ones. And when I talk with people, I usually ask them about the last 2 weeks. Over the last 2 weeks, have you taken little interest or pleasure in activities that you might enjoy? And if they say, yeah, I haven't been going for my walk, and I just haven't felt like reading. And I say, are you feeling down or sad or depressed? And they say, yeah, some days I feel sad. I know now that I'm going to continue with my questions. I know now that they're on somewhere in the world of depression. Sleep patterns, oversleeping, not sleeping enough. This is also a potential symptom of depression. Feeling really tired or having little energy. Sometimes depression really does manifest itself in sort of physical exhaustion for no reason. Feelings of failure and shame, feeling like you've let yourself down or you've let somebody else down. Moving or speaking really slowly. I've sort of talked about that in terms of affect, whether that be, their facial affect or their sort of vocal affect. Fidgeting, pacing, restlessness can also be a symptom of depression. And thoughts of one's own death or suicide. So this one isn't just necessarily for people who have expressed an interest in taking their life. It's also, when people say, I wish God would take me, or I'm ready to go. That can be a symptom of depression.
I have a quick question
Yeah.
in here. So as we talk about, I was my mom's caregiver
Yeah.
for about 6 months full time. And I think, I went through this with my father, who went through Parkinson's for 12 years. And at one point we were kind of like, I think dad might be a little depressed. Dad had always been extremely active. And when he lost his mobility with his Parkinson's, suddenly did not want to be seen, out in public. If he saw a friend, he had an instance where a friend didn't recognize him because he changed so much physically. And so we kind of were like, we think dad might be a little bit depressed. And similarly with my mother, in hindsight, I can look back now and say, oh, I think maybe mom was a little depressed. And I think what was difficult was, like blindness is often accompanied with other health conditions. And so my mother had an array of health conditions. And so my siblings and I were saying, oh, it's probably her medications that are making her sleep until 3:30 every day. Or, maybe she needs to go to the doctor and have more lab work done because we know she has all these physical things going on. But yeah, now that I look back on it and realize that, she had a lot of adjustment that she was trying to make, that she was probably experiencing some depression because she'd lost her husband and she'd had a stroke and she had to move and she was having all these health conditions. So at what point as a caregiver or friend, because we get a lot of emails, phone calls and whatnot from people who care about other people and their concerns. So how do you discern maybe between this might be something physical and medication related, or, when should I maybe think about reaching out because this might not be something physical, this might be depression, or it might be something emotional? How do we, what do we look for, and when do we make that call for their mental health maybe?
Yeah. I think that I think that for the second bullet point here of asking, of the person's admitted feeling, if they can identify that they feel down or sad. And when I do this, it runs on a scale of some of the time, half of the time, or all of the time. So that helps me. And I've asked this question in trainings that I've done for this before, where I'm like, well, some of these are just, if the person's telling me that they're sleeping a lot because they have, they're going to dialysis and they're very tired afterwards or what have you, I'm still told that I have to mark it down on the sheet. It's, I think there's always a mind body connection. I would definitely consult with a doctor to find out if, medications are having an impact on mood, or if they can have an impact on mood. But I think that they go hand in hand. I don't know if it answers your question though.
Yeah, kind of just, your point to maybe asking the physician if this is a possible side effect would be helpful in making that determination. Then if it's not a possible side effect and mom is still sleeping till 3:30 every day, that probably is a good point to say, maybe I should call somebody else, a therapist or a counselor. Yeah.
Yeah. And it's tricky because I think what we ultimately have to rely on is the individual to report what they're actually, feeling, which a lot of people aren't comfortable with that language, or there's a lot of shame and stigma associated to saying like, I'm feeling really down. Right. So I think it's also about the approach and how you're having that conversation, which is, I know it's so hard for family members. And I say that with identification, for sure.
Okay.
We'll talk a little bit about suicide risk here. That was the last question, like if a person's interested in taking their own life, or if they, answer yes to sometimes maybe feeling like they wish they weren't here anymore. So if you're a professional working with somebody and they express that, I recommend, if you're ever having those kinds of conversations, to go ahead and do a training for a suicide risk assessment. If anyone ever expresses anything along those lines, it's always a great idea. I'll just go over it briefly. I'm not going to go through this whole thing, but just going over briefly, following up a statement like that, or if you've asked that question, do you ever feel like a harm to yourself or to anybody, and they answer yes. You want to follow it up with questions to clarify. Have you had any thoughts about taking your own life? And if they say yes, that's not necessarily a big cause for, oh boy, we better get some professionals in here. But you follow it up with, have you thought about how you might want to do this? And if they respond like, yeah, I've really thought about putting all my medications together and, having a bottle of alcohol, and, if they've thought about that, the next question you want to move on to is, do you have those things? Like, do you have all of that medication? Do you have alcohol in your home? And if they say yes, so if they say yes to, they've thought about a plan, they have the means, and you also want to ask, what's your intention around doing this? Is this something you're really considering? Yeah, I think I am. That's when you definitely want to call 911 if they've answered yes to all of those things. If they have the idea, but they don't have the intention to do it and they don't have the means, you can go ahead and create a plan. Well, here's my number. When you're feeling like this, call me. Or here's the number to the Suicide Prevention Lifeline. I'm going to put it on your fridge. I'm going to put it in a voice memo here for you. We're going to make sure that you've got this information so that you can call somebody when you're feeling this way. What are other things that you can do for when you're feeling that way? And they can, tell you who else is on their emergency contact list. What's an activity that they can engage in, right? Okay, yeah, if I'm feeling that way, I'll go ahead and I'll do some knitting, or I'll, turn on my favorite show, what have you. I'll go and eat McDonald's, whatever it is that's going to make them feel better, or sort of move them away from this thought process. When in doubt, the Suicide Prevention Lifeline, I've included that information here. You can always call them. The client can call them, or the person that you're caring for can call them. You can also call them and say, hey, I'm with this person and they've said this thing and I'm worried. I don't know what to do. And that number for the Suicide Prevention Lifeline is 1-800-273-8255. So that's 1-800-273-8255. I talked a little bit about this here, a patient safety plan template. If you're super clinical, spend some time with these last couple slides. If you're in any kind of clinical role, it's great. And again, I recommend getting doing a training on suicide risk assessment and safety planning. This is just to sort of give you an overview of those things. So what do I do when somebody says yes? I've sort of gone over this to some degree. So as a social worker, if they're a danger to themselves or others, I assess, I intervene, and that can be anywhere from creating a safety plan up to contacting authorities and having the client placed on a 72-hour hold, right? So they are actively suicidal. They'll go to a hospital or a psych facility and they'll stay there for about 3 days until they show that they're no longer a danger to themselves. You can also refer folks to if you don't know where to begin, to getting people that sort of like emergency mental health. You can look up your community mental health, usually just Googling like community mental health and your area code or your zip code. That will be helpful. So let's move away from that really sort of acute experience of suicide and kind of move back to just the idea of depression, which depression is a big risk factor for suicide, but prior to it leading to an experience like that, there's lots of ways to intervene, and there's lots of ways to help people who are experiencing depression. And Hannan has a lot of ways to focus on helping people, older adults who might be depressed. A lot of these things are for people who aren't depressed at all, also, just to let you know. So also a little bit of my sales pitch on our programs and services here at Hannan. Hannan's basically split up into two sort of separate entities and departments, although we do a lot of planning and intersecting. We've got our arts and culture side, and we've got our social work side. And within our arts and culture side, well, we've got a fabulous gallery here at the Hannan Center, and we do lots of live performances. We'd like to be doing more, but pandemic, hopefully we will, but we'll have a monthly jazz concert series coming up, live music, all kinds of things. But we have an arts and culture program called Beyond You, which is creative aging. This gives opportunity for socialization, a sense of belonging. It's cultural education. You get to learn new skills, get physically active, and creative expression. And we have everything from an acting class, singing group, drawing class, yoga, tai chi, drumming. It changes up every now and then. And these are semester-long courses, so they'll go through like a whole season. I think we're in our spring, summer season. There's a catalog that goes with them. We do a lot of them on Zoom. We're starting to do a little bit in person. I know our acting class is meeting in person right now. So that's just to sort of give you an idea of that opportunity. Therapy, social work, it's not for everybody. Before being a social worker, I was a theater director myself. So I think that was, my outlet for mental health. And then we've got our social work side, which is where I am now. So I used to be in creativity. Now I'm in social work. I like to think I'm combining the two. On our social work department, our key things that we do are connecting older adults to the necessary resources they need to age with dignity. We do that through case management. That could be a single phone call where somebody says, hey, I need a number for XYZ, or I'm wondering where I might find out more about Medicaid. And I'll get you the information to call who you need to call about that. Other people have more complex things, and we'll work with them over a period of time to help them meet their needs, whether that be, they have an unsafe, something's unsafe in their home, or maybe they need some, they're having a landlord dispute and we need to help them find some legal services. Who knows? You name it, we've done it. We have a telephone reassurance program where we have a list of people that we call once a week just to connect, just to reduce some of that social isolation. And we've also got our mental health program. So you can do one-on-one counseling with myself or one of the other team members. And within that mental health support, we have a program that some of our clients like to do called Pearls. And I will go into a little bit here of how Pearls works. Pearls is an evidence-based, community-based program. And Pearls is an acronym for the Program to Encourage Active, Rewarding Lives. Okay. And this is a program that was researched and developed at the University of Washington, and it is primarily focused on late life depression. It's a great intervention for those who are experiencing mild to moderate depression. It's a problem solving and solution focused approach, and it promotes physical activity and social connectivity. Who's eligible for this program? Anybody. I think we're actually meeting people at 55 now. So this says 60, but anyone who is 55 and over experiencing mild to moderate depression. This slide is incorrect. We will work with people who are taking antipsychotics as long as they are stable on their mental health medication and have been for at least 6 months. We will take people who are carrying a diagnosis of a more significant mental health disorder, but as long as they are stable. We will work with folks who are mildly cognitively impaired. So if you're in early stage Alzheimer's or you've got some mild cognitive impairment, you'd be appropriate for the program. Anything beyond that, it's probably not going to be effective. We're available to people with insurance, and people who don't have the insurance that we take. We'll work with you. We'll figure it out, and it will be of no charge to you. Where is this Pearls or mental health? Where is it happening? Well, we'll meet you where you're at, right? If you want to meet by phone, we'll meet by phone. If you want to meet by Zoom, we'll meet by Zoom. If you'd like to come into Hannan for your sessions, we're happy to do that. I'm always available to go to people's homes. They don't seem to usually want me there. So, but happy to do that as well. So how does Pearls work? Well, we first do a depression screener, which is all of those bullet points that I went through before about are you feeling down or sad? Are you taking less interest or pleasure in things that you'd enjoy? Questions about your sleep, your behavior, your activities. And we come up with a score. So we'll give you a little number. Then we're going to identify some problems or goals, right? So a person is going to come in and say that they've got this, we'll generate a list of problems, right? I've got mail, a stack of mail that's unopened. I've got, I haven't talked to my son in 3 months. My backyard is, really overgrown, and my garage needs cleaning. And these are things that I haven't been doing because I'm feeling really down. So we will look at those. We'll select one. We'll do some brainstorming, some problem solving on what's the most actionable one right now. And we'll talk about what are the pros and cons. So the person that comes to me with that whole list will tend to arrive at maybe the stack of mail is what the goal is for this week. We'll set up a goal on how to approach that. We'll work together to set, maybe there's a day and time that it's going to be best for you to go through that stack of mail. What do you need with that stack of mail? Maybe you need a nice cup of coffee while you do it. Maybe you need to have a little treat while you go through the stack of mail. And then the best part is that you get to come back and meet with me the next week and let me know how it went. So the accountability is really important, but also some people don't meet the goal, and that's okay too. Like we're here to be non-judgmental and supportive. But the process is that we have a list of problems, we define the problems, we generate some ideas, we look at all the different possible solutions, and then we pick the easiest one and we go from there. So how does this work? The idea is that it's a positive cycle of activity. So if a person's feeling depressed, this is what I talked about earlier when I said we're going to break this cycle. Is my mental health making me lonely, or am I lonely because of my mental health? We're going to engage in behavioral activation. So we're going to do more meaningful stuff, which is going to lead to us feeling a little bit better, which hopefully makes us feel like we want to get more out of life. which then makes us want to go and do more things. But we're going to start off easy, and sort of like the beginning of the Tina Turner song. We're going to start off nice and easy, and then we'll ramp it up. Proud Mary. We meet with people for the first 3 weeks of this intervention. We meet with people once a week, really get it going. Then, because the idea isn't that like we're the thing that keeps you going, you're the thing that keeps you going. Then we drop down to meeting once every 2 weeks for 3 sessions. So hopefully your goals are becoming a little bit more full, a little bit more complex, and you're taking the time to work on those really independently. And we're meeting back for every 2 weeks for 3 sessions. And then after that, we'll do, 1 or 2 follow-up sessions over the next couple months. And the studies show, and the experiences that I've had with clients, is that we do see the symptoms of depression reduce. So this goal that we work on each time, it's also paired with a suggested, this one I won't hold you accountable for, but suggested physical activity and social activity. So you're going to go through that stack of mail there. What else? What can you do for some exercise this week? Well, I'm going to take a walk. Okay. And what can you do for social activity? Well, I'm going to call my old friend from college. Okay, great. Or you can take a walk with a friend and do it all at once. So I hope that gives you, I know I went through a lot of that pearls stuff really quickly. I hope I've sort of given an explanation or narrative or examples that are helpful, but ultimately the idea is that depression is linked to unsolved problems. We're here to help you identify what those problems are and brainstorm with you workable solutions. And we're here for you to be accountable and report back on your progress.
So how will people get more information about Pearls? How do they get in touch with you to perhaps take advantage of some of the services at Hannan Center?
Yep. People can call me at 313-908-0183. Again, my name is Daniel Horrigan at the Hannan Center. That's 313-908-0183. You can also email me at dhorrigan, HORRIGAN, at Hannan, HANNAN.org. And if you think that Pearls isn't a fit for you, we also do traditional talk therapy. So we, if people are experiencing something other than mild to moderate depression, whether people are experiencing a grief and loss, chronic pain, any type of emotional or mental support that you need, we're here for it. And we use a variety of interventions. Pearls is a nice one for people who maybe aren't really into therapy, because it's a little bit more hands-on and it's a little bit more about you just taking some steps. But if talk therapy is something that resonates with you, you can also reach out in that regard.
Thank you for your time today, Daniel. And I know that you and I will keep in touch, and hopefully if anyone listening in has any questions, the numbers will be provided in the post as well. And we hope that people who are in need of support choose to reach out.
Great. Well, thank you so much. It was a pleasure to be here.
Thank you.